Okay. All righty. Good evening, everybody. Thank you for joining us on this edition of the Osteoscience Foundation's Generation Over Generation podcast. I'm Dr. Patrick Wong. I'm an assistant professor at UT Southwestern/Parkland. Recently completed my craniofacial surgery fellowship in Oklahoma City. But before all of that, I spent 10 years as a student in resident training under our guest this evening, Dr. Likith Reddy. Dr. Reddy completed his residency at Parkland and UT Southwestern, spent some time at Cincinnati as a program director and the chair in New Orleans, and then has spent around a decade as at Texas A&M/Baylor, where we got to know each other, where he is currently the department head and chair. And he's also probably the biggest surgical influence on my career. So thank you so much for joining us today, Dr. Reddy.
Patrick, thank you again. Appreciate the introduction. And first of all, congrats on your engagement, by the way.
Oh, thank you, Doc. Thank you very much. It was a long time coming. Definitely better to do it after fellowship. So a lot of life changes coming up, engagement, new job, all that stuff.
Yeah.
But my first question today for you, Doc, I kind of know your path. You have a little bit of a non-traditional path into OMFS. Can you kind of tell us how you got started in the specialty and, were there ever any doubts that you were doing the right thing along the way?
Yeah, so I did my my undergrad, that is a dental school degree, BDS in India. And in India, it's about 5-year training after high school. So you don't go to a college basically. And so I did 4 years there, and then I came here. And I was lucky enough to be accepted as like a pediatric dental foreign fellow. And I did about a year. I got to tell you, it was an interesting culture shock for me. Number one. Number two, I never really learned how to handle kids in my training in dental school in India, but then came here. It was a quick learning experience. So, but after that, my entire intention was always to do OMS. And I knew the best path was to do an advanced standing. At that time, there were only about 4 or 5 programs. And I applied to 2 schools, Penn and Case Western. And why? Just because Penn had a track for foreign trained student dentists, and Case was because that's where I did this pediatric stuff and familiarity and had family. So that's how I got into this, and then I applied. I didn't have a good enough track record or background in the United States with my education, so obviously I didn't get any interviews the first time when I applied, even though I did pretty reasonably well in my scores in NBD, National Dental Boards and stuff like that. So it led me to a path to doing a GPR, and then I did not really. It was good, but I wasn't certain. So I applied. I had some interviews. I'll be honest, I was clearly unprepared for OMS training. Then subsequently, I was fortunate enough, I got into UT Southwestern Parkland and for residency, and so for internship, and that's really where I built up most of my stuff. And I was very fortunate. I had the right mentors also, and they're dramatically influenced in what I do right now. And so that's how my career started.
Yeah.
But I always knew I wanted to be in academics from the beginning. So it is something very influenced by my dad. My dad was in academics the whole time. He was an orthopedic surgeon. And then, so I chose to do that. And he enjoyed teaching, and he enjoyed training his residents. And they, used to keep in touch with him all the time. And I really liked that part of it. So, so that's why I chose to went to Cincinnati. Why Cincinnati? I basically took a little compass and then drew a 5-hour drive distance from where my sister and my brother was, and that's pretty much where it fell. So applied to a few programs and got accepted to both, and then I chose to go to Cincinnati.
Yeah.
And then from there to New Orleans, it was a great opportunity post Katrina. It is one of the best things I think I've done. It's an amazing learning experience, especially from, we don't really learn how to do administrative tasks, how to set goals, how to set where we should be in the future. And so this is an opportunity where going to New Orleans has provided me and really prepared me for where I would call it the second time, at Texas A&M, that I was able to really understand the culture, develop the goals, and really continue to build our program.
Yeah. I mean, it's a very kind of non-traditional path, but obviously I'm really grateful. You kind of talked about how the residents kept in touch with your dad all the time. And I know every time we go to Amos and I'm trying to like walk and talk with you, you get interrupted like 50 times by former residents trying to talk to you. So I guess you kind of followed in your dad's footsteps there. You talked about your mentors, and I kind of know Dr. Ellis is a big mentor of yours, but could you kind of touch on who's kind of shaped your path along the
Yeah.
way?
My biggest influence has been Dr. Ed Ellis. I'll be honest, I regard him as a very good friend and still continue to be a mentor. I enjoyed my residency, but beyond that, I also had a lot of other faculty who played an influential role. Dr. Sin was very, influential in some of the certain aspects of our specialty. I like Dr. John Stella, R.B. Walker, he was there. We knew some of the qualities of a leadership and how you could be, the last 2 years of my residency, by that time he retired, but he was still an emeritus professor and he used to be there for all our meetings. So it's really, I think, every single one aspect of it. I pick something, I think, from each faculty as to what I want and what I like. And I try to utilize some of those skills that I've gained during that training. In addition, when I went to Cincinnati, I did have a faculty, Dr. Robert Marciani, who was extremely supportive in my career growth to see where I need to go. And then during my battles, there was a lot of significant political battles that I encountered when I went to Cincinnati. The Cincinnati did not, our specialty was much more focused on dental alveolar surgery and maybe mandible trauma. And all of a sudden, I go to environment from Texas, which is pretty broad, in our training. And then it was a challenge, constant political battles, constant, I had plastic surgeons or ENT surgeons come and say, that's not in your scope, even though I had privileges for most of these things. But I did have some right mentors in that training part of it. One was a chief of, surgeon in chief at Cincinnati Children's, who helped me tremendously. And then I also had chief of surgery who was able to help me in some of the path. And then the chief of neurosurgery, with whom I was able to do quite a bit of work. And they kind of helped me basically navigate through some of the political, I would call, battles. But in a way, I'm glad I had faced that, because if not, there is no way I would have learned how to handle scenarios if I go to another place. It's really just taught me what to do. I mean, it's the same thing when I got here. Our scope was a little bit narrower within our hospital. We were able to expand the delineation of privileges pretty broad, and not only just targeting me, but it's actually for all our entire specialty. So any faculty who comes here is able to do those things, and not be stopped by some political environment. At least that's my intention, and
Mhm.
that's what I really look at it. And so if I get any resident or any faculty into our program, my goal is to make sure that they're able to succeed and that I'm able to alleviate some of their uh, political issues and limitations from other services, is the way I want to put it. So
Yeah, so I think that's something that really has come to define your career. Whenever I go and talk to people about you or kind of describe my training and they hear that I trained under you, I think the one word that comes up more than anything is fearless. People will say stuff like, oh, Likith is fearless, he'll do anything, or, he's not scared. And, you kind of mentioned when your career first started, you were fresh out of residency in Cincinnati, you hadn't done a fellowship, but you were, doing all of these cleft and craniofacial procedures. I guess, how did you kind of navigate that fear that, am I ready to do these things, or, am I capable of doing these things, and what can be a hostile environment?
Yeah, so learning never stops. I will tell you that. It's interesting. When I finished my training, and I think I trained under somebody who's regarded as the guru in trauma, one of the gurus in trauma, and in mandible fracture especially. I still, when I finished my training, my first few years, I'm not kidding. I used to read a lot of articles about mandible trauma still. Okay, it's something which is so innate that you kind of knew very well. So that's one of the things. In addition, I was very fortunate to have a close friend of mine in India. When we started our dental school, we started together, and who started the second smile train center in the world, basically. And it is the busiest smile train center in the world, where a lot of foreign trained fellows and a lot of European surgeons come and train with him. So one of the things, when I finished my training, I obviously had an exceptional experience with orthodontic surgery. But in India, and this is with I was used to do almost once a whole month. I used to go there, and I was kind enough. I mean, my mentors were kind enough to actually Ed Ellis was kind enough to let me go, even during my residency onwards, third year of residency. I used to go, and one of the things I asked him was how to train me and teach me in cleft lips and palates. So by the time I was done with my residency, I pretty much had close to 35 to 40 cases of cleft lips in my experience there.
Hmm.
And so not only he has, and obviously I taught my friends how to do orthodontic surgery, but they've taught me how to do some of this elements of craniofacial surgery and some cleft lips and palates and stuff also. So that's one. So by the time within my fifth year of my post residency, I was probably had the opportunity, fortunate enough to do both, with privileges in US as well as privileges in India, almost as much as a fellowship, or far exceed even a fellowship training, because close to 200 cleft lips or so I had done that by within my first 5 years. So that's a tremendous experience. So that gets you that comfort. In addition, I've sought out mentors. As I mentioned to you, when I went to Cincinnati, I was able to work with a neurosurgeon. We used to consistently go to his lab. It's at the Mayfield Clinic in Cincinnati, and we used to do a lot of dissections together.
Hmm.
And that's one of the opportunity where we were able to do something through the eyelid, the keyhole access incisions through the eyelid. That's how we developed that. And so that's how some element of that, again, how they build up. Then in addition, when I went to, I frequently walk into other surgeons who I regard them as friends. Doesn't matter what specialty it is. And I just observe them. And that's another thing. You work with cadavers constantly, you dissect, you do anatomy, you're able to visualize mentally where anatomical structures are going to be. That's another part of it. In addition, when I got here, I obviously had opportunity to work with some of my colleagues, in addition to, with Fort Worth and Duchek with doing, micro and stuff, something that, so I was working with chicken legs and just do the micro practice stuff by myself, and then work with Duchek, who was doing this ridiculous volumes of these flaps. So it gives you a wide variety, even though I don't have any interest in oncology, as you know, but I think reconstruction and bringing in distant flaps for reconstruction is a tool that is going to be very helpful in trauma, and even in some situations of pathology, benign pathology, and even in some cleft and craniofacial scenarios also.
I
So,
don't think anybody in the country has as wide of a scope as you do. I mean, especially for somebody who, you're not fellowship trained, but you do everything. I mean, you have privileges to do flaps, to do clefts. I remember, when I was the trauma chief, anything that came in when we didn't know what to do with it, I would purposefully just staff it with you, because you would always kind of know what to do. You'd always have an idea. Um, and as we're talking about, you know, your time in Cincinnati as kind of a, learning or doing a lot of cleft and craniofacial procedures, then when you went to New Orleans, your practice had to kind of shift. And then when you went to Baylor or Texas A&M, your practice had to shift again. So you've kind of had all these, career moves, but you've kind of just adapted your practice to whatever, has kind of been there. So how do you kind of, navigate those big transitions? You're taking a new job, but you're having to practice a completely different, branch of surgery.
So Cincinnati, when I went, the commonality between all these three locations is trauma still. Trauma is something I've always done in quite a bit of numbers. The orthognathic surgery has been quite a bit. I was able to build when I was in Cincinnati. But when I went to New Orleans, the path changed there. The orthognathic volume was not that much. However, I was fortunate enough to lead one of the craniofacial teams at Tulane. And it was just a coincidence. It's a plastic surgeon who asked me, hey, can you come and be the lead for our team? Which is unusual because they lost somebody they had, this is all post-Katrina. And so that was one with one team, and the other team I was just a team member too. So I was able to get the opportunity to work on both two different competing groups basically. And we were the sole OMS team which was there. And in addition, we went to children's and said, hey, we want to do X amount of trauma, and there was not a lot of hesitation. We were able to do pediatric trauma also. But when I got to Dallas, that's one of the things I desperately miss is the craniofacial element of it. Yes, we do a lot of orthognathics and a lot of adult craniofacial, but I was able to do a little bit more of evulsive defects with some distant flaps and stuff like that. That's what I was able to do it. And that's really the orthognathics and TMJ surgery. Part of it is there is just a demand here. I think it's a big city. Much smaller group of surgeons do some of these surgeries consistently in the OR. And I think it just automatically I was able to build that volume up. Um, Overall, my strategy has always been whenever you go to a different place, you want to really focus on it's very difficult to go and say, I want to do this wisdom teeth, or I want to send me these cases for orthognathic surgery. People are not going to be, they don't want to change their referral patterns. People are hesitant to do these things. So the way to do it is you're going to pick up the cases which are the most challenging stuff. That's the bottom line. And there are going to be other surgeons who would be willing to give away, is the way I want to put it, or may not want it, or they don't feel comfortable, or they don't want to spend so much of time on some of these cases. This is
Mhm.
how you build your reputation. In addition, there's no shortcuts in this. You consistently have to practice and train, and you have to operate. I mean, my entire career, I don't think at any place I've operated less than 3 days a week in the OR, and at any time. I mean, there were times when we had 2 rooms, 3 rooms sometimes, but and there are 5 days, 7 days, and we're talking consistently for now it's almost 19 years, I think, 20 years now. So that's a lot of operating volume, and that's the thing there. So, and I think that's the key is that to keep up with that. That's the only way you can keep up with your skills and keep up with, you're able to do a wide volume of cases.
Yeah, and I think it's really inspiring. For me, I'm kind of starting, my career, and I have really admired the fact that, really whatever came in, I don't think once you've ever said, oh, I don't know if I really want to do that case. You always just said, yes, we can do that. Or, oh, I know exactly what to do. You'd always say, oh, doc, it is so easy. You'll see, and you were right. A lot of times I used to hate it whenever we would kind of, bicker about something or argue, and then you'd be right.
Yeah.
But um, talking about, starting careers, since I'm about to start as an attending, what's some advice that you have for sort of a fledgling attending?
Yeah. So number one, be humble. Believe me, I've been humbled many times too. So that's number one. Number two is that understand the overall, the landscape. I think one of the major mistakes people do is that when you are starting your career, you're no matter what, you are still an unknown commodity for the university or for the other faculty. They really don't know about you. So the best way to do it is to demonstrate that you're capable. That's right. I mean, you are available, you're able to do the cases, you pick up the cases, and then just be modest about it, to be okay, because if you have better outcomes than your colleagues, still be modest about it. Don't say anything else about it. Okay. Um, then the next thing is there is always, you're going to an environment of UT Southwestern, there is going to be a very strong plastics or ENT that some of them may not like you for that. Okay, it's a possibility, not because of you, not because you're a bad person or anything, just because of what you're capable of doing it is going to bring some animosity from other groups. That's just a natural. So in those scenarios, don't take it personal. Another example, if you're doing a case together with another surgeon, even though you may have a higher expertise than the other surgeon, uh, just do your stuff and they will recognize it. That's the bottom line. And when the outcomes are good, nobody's going to say anything. I mean, as I said, I'm going to give a great example. When I got here to Dallas, and I had this case which was operated previously by a very famous plastic surgeon, Kenneth Sawyer, and he done like on this Apert syndrome patient for about I don't know, about 10-15 surgeries since his childhood, and his foundation was paying for him. Patient came to me for basically getting out teeth. I'm not kidding, taking out teeth and dental implants possible. That's what it was. Literally, one of the eye was completely proptotic and rotated outward and lateral, and this forehead is massive bulge, massive, basically a mucopyocele affecting the entire ethmoids, orbits, orbital wall, cranial base, everything was gone. Okay, and the patient, we talked to the patient and literally did that. We posted the case, obviously, and did all the things we needed. Not only that, cranial base reconstruction, but forehead reconstruction, the orbit, everything.
Mhm.
Sawyer got very upset when he knew I was going to do the case, but the patient was insistent that they were very comfortable with me. I'm not kidding. 2 weeks after the surgery, the patient was discharged. I think the patient saw Sawyer about maybe around 2 months or so. And he was so happy with the results that he personally came to my office and brought his granddaughter with him to
Wow.
introduce there. So because she's interested in doing dentistry.
Mhm.
So this is what it changed it. Now, and that's what I'm talking about. I'm going to give another example. At ENT, when I went to Cincinnati, one of this ENT surgeon absolutely did not like me
Mhm.
because he felt I was competing there. I was doing the zygomas and orbits, and traditionally OMS did not do those things. And his son is a fellow of Tuchik, and now his dad apologized to me that how he was at that point. Remember, I was just so brand new at that moment. But as I said, I did not take it personal in any way. At that moment, you feel very angry, but you just hold back and then don't take it personal, and that's the way to do it. Things
Yeah.
will change.
Yeah. A patient who comes in for a tooth extraction and ends up with a craniofacial surgery. That's a very Dr. Reddy treatment plan there.
Well, you look at the patient completely, you don't miss something there, and you don't get fixated on the tooth, right? It's
Yeah.
not like we were doing unnecessary surgeries. Literally, this was the only good eye this patient had. And so, but we were able to do a variety of stuff. Yes, in addition, she had a cleft palate, which was repaired also. And then we were able to, get the teeth out in addition, and then actually end up with the prosthesis, which was the biggest challenging part because the financial means was a challenge.
Yeah.
So, yeah.
I remember as a chief, I had somebody come in for an implant, and then she had briefly mentioned something joking about a facelift. And then you and I did a facelift on her about a month later. So that's kind
Yeah.
of the Dr. Reddy special, come in for teeth and then you end up with a nice major surgery. So
Yeah. Remember, we don't talk patient into it. We just we
she
just
asked
discuss
about
if
it.
they have some concerns and stuff or issues that they address. And because sometimes they don't know, that's what we do. Especially when we're in dental school, our clinics are, it's much more challenging because patients are not expecting that we do these variety of stuff
Mhm.
until they're aware of it.
Yeah.
So,
So I did want to tell a story about you, and the story kind of has a question at the end, but I'm sure you don't even remember this. I'm curious if you remember this story at all. But when I was a fifth year, we had just started taking call at Harris, which for the listeners is a level 1 hospital in Fort Worth. but we were all based in Dallas, and Fort Worth is 45 minutes west of Dallas. And at the time, the attendings were fielding the calls and then just texting the residents to go see consults. There was one weekend where I was the fifth year, and you had texted me, you know, about some patients, and I'd gone out there, then driven back, then I had driven out there again to go see another patient. And so I had driven out to Fort Worth twice on like a Saturday. And then I wake up Sunday and I'm texting you asking, if there's anybody that you want me to go see. And then you had told me that there was a lac that you had closed in the middle of the night at like 3 a.m. And you had driven out there by yourself as the chairman of the department. And instead of waking me up and having me go out there, you went and did it yourself. So that was a very kind of formative experience for me, because I saw it as, well, if the chairman of our department is willing to drive 45 minutes to another city to close a lac in the middle of the night, when he could have easily just texted me to do it, then there really is, nothing that I should be above doing, as the chief resident. And I tried to stress that to, the junior residents and all of the interns that, hey, if our chairman is willing to do this, you can't really be above doing anything. So I just kind of wanted to ask you about that. That was a very kind of subtle show of leadership. You didn't have to say anything, but just out of your actions, you kind of really showed me a powerful lesson. So can you kind of talk about that style of leadership that you have?
Well, thanks, Patrick. The point is this. I don't want to put somebody through, or I don't want to pressure somebody to do something that I'm not willing to do. That's just my philosophy. And I don't think it matters what level you are, what role you're in. That's my view. And I think a lot of my the residents who I graduated with, they're very thankful. I assume that's the thing. Because I understand that, you driving to a hospital, which is 45 minutes away, 50 minutes away. That's pretty hard. It's 2 or 3 times. Sometimes it's very, very challenging. And we knew that at Harris, it's a super ultra busy hospital now. So I just did not, I was already awake, and I thought there was when I got called about, I wasn't certain if this patient needed to go to the OR or not. So no matter what, I need to wake up and reassess this patient. So two ways I looked at it. If I'm going to be there, might as well just finish up the case. That's the thought I thought. And then why bother you to go? If this is of significant learning value, then yeah, absolutely. I would have, without even a question, I would have said, hey, Patrick, you need to be here. Let's do this case. But some of it is not anything major. It's more of a scut work. That's the reality, is that, might as well, I'm there, might as well finished off is what happened in this. But in general, if you know me, that I take a lot of call even now. People don't realize it, that I take an average of 1 to 2 weeks, sometimes even 3 weeks a month of call. And the intention is that I can't say I'm going to pick and choose the best cases just because I'm a chair. I'm going to do it because when I'm on call, these cases come in, that's what I'm able to do it. That's the view with that. So I think the goal is that before you ask somebody else, you should be willing to do that. That's the way I look at it. It doesn't matter if they are your other colleagues, other faculty, even if you're a department chair, or even your residents. That's the way I look at it. So that's my philosophy on these things. So and now all of a sudden, if you notice, all our faculty are willing to take call. And in the beginning of my career, I used to take most of the holidays in such a way that, especially when I'm making the call schedule, I still put myself on some of the major holidays, because this way I don't feel like I'm abusing it. And also they will actually gain respect. Now, more because other faculty are more than happy to pitch in and take the call now for those.
Yeah. I'm surprised you do actually, so you do actually remember that. You remember it quite well. I mean, it must have been
Yeah, I don't remember the specific scenario, but it's not, I've done a few times, I know that. So and it may be one time it happened with you. So so
Well, you kind of remember, but it was
yeah.
very formative for me, kind of just seeing, somebody who, display leadership without having to really say anything by just doing, a simple action. So it's always stood out to me. While we're talking about leadership style, I also wanted to kind of talk about your teaching style. I mean, for those who don't know you, I think you would agree that you have a very fun atmosphere in the OR. There's a lot of joking around. In fact, I think in Oklahoma City, I kind of surprised some people with how much I was joking around because I was used to operating with you so much. But how is what is your philosophy sort of on keeping the operating room atmosphere kind of light and enjoyable?
Yeah. So my philosophy is, I think I've always mentioned it to you. When you go to the operating room, you're operating cerebrally, you're thinking about it, right? So, and then with time, it becomes a lot of muscle memory, basically.
Mhm.
So the prepping for any case starts before you go to the operating room, period. Okay, that includes, sometimes visualizing the surgery in your mind. Sometimes I think we've mentioned to most of you guys, when you lie down before you go to bed the next day about surgery, you're really trying to figure out how you're going to stand, how you're going to retract, how you're going to position, what are you going to do. All those things, when you repeat it, it comes there. So that means your surgery, you've already done a lot of prep there. So that's the whole point. And so in the OR, the tendency is that there's no need to be super stressed out about something. If you're prepared for it, it becomes a lot easier. When you're not prepared, then that's a different story. And so and I used to do that all the time. And so just before any surgery, especially in the beginning, often I used to prep in my head,
Mhm.
how do I move it, how do we do these things. I said so I think I think when the mood is very relaxed, I think people do better. That's just my view. If you're prepared and you're relaxed, in a relaxed mindset, you will do better. That's the way I look at it. And if I'm going to spend time with residents, I might as well enjoy spending time with them.
Right.
And that's the way I look at it. And I do think I'm very invested in, that in residents, because I do like to know them very well on a personal level. I like to know how they are, who they are, because that way you can vary your teaching level with different people. And some residents like a certain ways versus some others. I'm not saying you'll become perfect with every resident, but majority of them you're able to understand their working style, and then you're able to hopefully teach them certain things that they carry on with the rest of their life.
Mhm. I definitely can attest to that. I think, it's working with you is so fun that I really have come to miss it. And I talked to a lot of the previous residents, and I think one of the things that they always say is, "Oh, I just miss operating with Dr. Reddy." So, the constant joking around. I have another story. I'm curious if you remember this one. So, do you remember, once again, we had just started at Harris, and we hadn't been operating there for very long. We had, just kind of done a couple cases here and there, and you and I were kind of, as we always do, kind of giving it back and forth, kind of bickering, but in like a lighthearted way. And the scrub tech asked if you and I were father and son. Do you remember that?
Yeah, I remember that. I think that's pretty funny, but
Even
that's okay.
though, yeah,
That's
you're
great.
Indian and I'm Asian, but she somehow thought that we were father and son just by the way we were talking to each other. So,
Yeah.
uh,
Well, the the point of it is that you want to have that easy conversation with your residents, and the residents feel comfortable to reach out to you, and in such a way that that you could be an appropriate, you can guide them through. If you are unavailable or unreachable, you can never really be an effective mentor. That's the bottom line. So and so this, because you're always at a different so part of my philosophy is that I do want to take very bright residents, there's no question. And I do want them to think, and I want them to challenge things, and but at the same time, when you make decisions as a faculty, you got to have specific reasons, not because it's the way I've done it. You also need to have a reason why you're doing certain things. And when you're challenged, you'll step back and you'll think, and that's the whole point of it, because you need to be challenged, otherwise we were not going to continue to improve.
yeah, yeah. So kind of switching gears here, I wanted to ask you, I think, this is sort of something that as a chief, you kind of talked to me about, which is achieving a good work-life balance. As a surgeon, obviously, we dedicate so much of our time to this job, and you sacrifice, in a lot of cases, your entire 20s to do this job. So it seems like you should be spending, quite a bit of your life after training doing, at work. But what's your philosophy now on work-life balance and all of that?
Yeah. Work-life balance is a term we all use, but it's very challenging. It's very difficult to say what that is. The way I look at it is there are times that you will have a little bit more flexibility, that you're able to work a little bit more and not be, and it's okay, you're not able to spend that much of time, but then there are times that you have to spend a lot more with your family versus you may not be able to work at your full capacity. That's really, it's a tough balance and a tough challenge, especially if your spouse is also working,
Mhm.
and then you have children. That makes it much more challenging. So I cannot tell you. I have seen some colleagues of mine, and where they're very dedicated to work and stuff, but then then their children, and then you're working till s- late into your 70s, 80s, and 70s and stuff like that, just because you have to continue to support your children. Okay,
Mhm.
I don't want that. The whole point of it is we want to be available for children. You will not get that opportunity. You also, and so I think it's critical how you adjust your life. One of the things I do now is, you all know that I start the OR at 8 o'clock, not at 7:30, even though the hospital insists it should be at 7:30. But now they got used to it. Now they, in fact, even if you post at 7:30, they'll move to 8. Part of it is, for that adjustment is for one simple thing. I drop my kids off at school at a certain time, and that's the only way I can make it to the operating room, to the hospital. I think that just that little dropping off for school made a big difference in them. They all of a sudden they feel like I'm there, even though it's not like I'm doing anything different, just starting 30 minutes late there.
Yeah.
And that, I think that small adjustments would make a difference. This was an eye-opening for me, because when in my previous job, there was a time that I did not see my kids, even though we were in the same house when they were small. For about 10 days, I did not see them. We were in the same house because I left before they woke up, and I came home after they went to bed. And then, I left New Orleans in a very tense situation because of significant, frankly, friction between the dean and I. And but then it made me rethink, what is this for? I mean, I don't even see my kids. What is the purpose? And that's how I thought about it. All this hard work for what, is my sense. So I think that's why I adjusted some elements of my life when I got here.
Yeah.
So
Okay, so this last question, and I know you can talk forever on this subject, but what are your thoughts on sort of the future of OMFS, AI, machine learning, and all of these things? I remember distinctly when I interviewed for residency, and all of this stuff was kind of like in its, infant stages. We had a discussion, I'm sure remember, at Dr. G's house, and you talked to me for probably 30 minutes about machine learning and AI back then. So, now it's kind of at the forefront of everything. So what are your thoughts on, AI and its implications in our specialty?
So AI is going to become quite a bit part of our normal life. It's just going to become a thing of, and an example is that, one of the research study which we started with, and then Reed Fuller got the grant, Chuck Milam Award also. An example is orbit surgery, orbital reconstruction post trauma. At best, is a guesstimate. It's based on our experiences. We say this much of displacement, this much of volume change is what we think it to be. We have shown with our studies that with our automatic segmentation and stuff, often we overestimate or underestimate based on the size and location of the defect. Okay, so that itself lends to issues of, so really we are so worried about complications. I think we overdo surgery. That's the way I think in this thing. So you're going to have things like this developed in such a way that you can predict. You're also going to have situations for oncology where it's going to tell you what is the latest and the greatest, and based upon gene markers and based upon biomarkers, basically, to figure out what may be the best option to do this, in addition to just not surgery or radiation or anything like digital imaging. You're going to do that. How do we read the scans? And not only that, I think one of the things it's going to tell you is, let's say wisdom teeth is a good example. It probably will be able to predict, somebody's going to come up with that in such a way, what is the probability of injury to the nerve because of taking out so and so teeth. Okay, that's what's going to happen.
Yeah.
So it is a future. And in addition, I use constantly for my email. It automatically generates an email response for me, and I use it all the time. All of a sudden, my emails have become better and more polite and more organized to formal also. Uh, so this is just it's gonna happen. This automation is gonna creep in. It's gonna happen. It's just the new future. And also, how we test the students or the residents is going to be a little bit different.
Mm.
And the reality is we can get upset about it, but the point is there's data and information available to everybody instantly now. And the way we teach them, or the residents or the students, is that how do they utilize the data and how do you put that into use? That's really what it is, rather than what you're memorizing. That's the reality. That's how you should be doing that. Yeah, I would be happy to talk a lot about machine learning and then deep learning and neural networks, but I think we'll leave that there because it's going to just go on forever.
Yeah,
So
I know you could fill in hours of content talking about the subject. No, that was great. And I think that's a good ending point right there. Thank you so much for joining us, Doc, and thank you to the Osteoscience Foundation for letting us have this chat this evening. Anything you want to add, Doc?
thank you very much, Patrick. Appreciate this, and I'm glad we were able to catch up this way. It's been a while actually, so come on over and we can talk further at school.
Yeah,
Okay, okay. Thank you.
thanks.
To learn more about Osteoscience Foundation, visit osteoscience.org or follow us on Instagram, Facebook, and LinkedIn.